interstitial lung diseases. So last time we were here, we looked at some bronchiectasis, then we also looked at some lung cancer. Let's look at the interstitial processes. There are three interstitial processes. One is pulmonary embolism, pulmonary fibrosis, and interstitial lung diseases. Let's start with the interstitial lung disorders. So what is interstitium? Interstitium is the space between an alveoli and an accompanying blood vessel. In fact, the yellow structure here, which is supporting the alveoli all around, is a fibroblastic tissue, and that is the interstitial space. Diseases of the interstitium interspars, or rather include diseases which occurs in the interstitial space as well as the blood vessel. The most common disease that occurs in the interstitium is called as fibrosis, so we will call that as interstitial fibrosis. You can also have a clot in the pulmonary vessel. That would be pulmonary embolism. Third possibility, this vessel may have high pressure. That would be called as pulmonary hypertension. So the interstitium includes the fibrous space around the alveoli, the alveolar wall, the lymphatics in this fibrous space, as well as the vessels. If I talk about the interstitial lung disorders, basically it's a group of disorders which affect that fibrous space. Some things are common to this problem. It can occur from many causes. The fibrosis in the interstitium can occur from many causes, but they share a similar clinical course, radiological course, physiological and pathological manifestation. That's why they are clubbed together as interstitial lung disorders. Few more of these should be very clear to you, that all these diseases have poor prognosis. Some, if they catch early, are reversible. They're associated with significant morbidity and mortality. There may be some difference in opinion between one pulmonologist to the other regarding the management. But make no mistake, all these disorders results in a restrictive ventilatory defect. So let's look at these disorders in a little bit more closely. On the left-hand panel is a normal-looking lung. By now, we have become an expert. Trachea, the cardiac shadow, and its associated organs, aorta, etc. Right side of the lung, left side of the lung, the diaphragm. If I biopsy the healthy lung, these are all the alveoli. The alveoli associated with each other. In between the two alveoli is the interstitial space. On the other hand, if you look at a patient with pulmonary fibrosis or interstitial lung disease, and these two terms are interchanged, connoting the same process, this chest X-ray does show some changes. We'll look at that in a minute. And if I have to biopsy this lung, it's no longer normal looking, not at all. The nice alveoli are replaced by thickened interstitium. As you can see, this is the blood vessel, this is the bronchus, and things like that. So the point well taken. The alveoli now surrounded with a thick layer of fibrous structure, and gas exchange is impeded. So one common theme of interstitial lung disorders is these patients may look normal at rest, but on walking, they desaturate. They may look normal at rest, they do look on walking, they desaturate a lot, their oxygen saturations go down. Okay. So interstitial lung disease is the umbrella term. Interstitial lung disease is the umbrella term. It can be from many causes. When the cause is not known what caused this, we will call that as idiopathic pulmonary fibrosis. Interstitial lung disorders, if the cause is known, well and good. If the cause is not known, we'll call that idiopathic. Sometimes some clinicians, when they mean pulmonary fibrosis, it's interchanged with interstitial lung disease. So in general, pulmonary fibrosis means any kind of fibrosis. Because there's more than 180 causes of interstitial lung disease, it's not possible for you or even when my residents and fellows to remember all the causes. It's not necessary. But we can subdivide this group in a way that is easy for us to understand. So, okay. Interstitial lung disease is a group of disorders which have a common theme of restrictive ventilatory defect, fibrosis around the alveoli, leading to hypoxemia, respiratory failure. If the etiology is known, there are 3-4 of these. Connective tissue disorders like SLE, rheumatoid arthritis, scleroderma. Medication-induced, something you should need to know. The medications are a common cause of interstitial lung diseases. Very important for you to remember is one drug which will hold you good stead all the time. That is amiodarone, can cause pulmonary fibrosis. For some reason, amiodarone accumulates in the interstitium, causes inflammatory reaction, causes fibrosis. You can also have a few occupational exposures, and I've been talking about this during my lectures up till now. We visited this in my first lecture. We talked about interstitial lung disease due to asbestosis, coal workers' disease, silicosis, etc. So interstitial lung disease, known causes, 3 of these, very simple. Connective tissue disorders, drugs, occupational exposure. Radiation-induced fibrosis does occur if patient has had radiation to the lung, not that common. Second group of patients are those who develop specific kind of injury pattern in the lung. They develop granulomas. It's like a T-cell disorders, T-cell inflammation, type 4 antigen antibody reaction. 2 of these conditions are sarcoidosis and hypersensitivity pneumonitis. Sarcoidosis and hypersensitivity pneumonitis. Then there's a whole group of patients whom we don't know why they develop this fibrosis. We club them as idiopathic interstitial pneumonias. We divide them into 2 types. Idiopathic pulmonary fibrosis and non-idiopathic pulmonary fibrosis type interstitial pneumonias. And this group has many idiopathic causes. Please don't go crazy remembering these names. These are non-specific interstitial pneumonitis, organizing pneumonia, respiratory bronchiolitis, discomatous interstitial pneumonia, acute interstitial pneumonia, lymphocytic interstitial pneumonia, and pleuroparenchymal fibroelastosis. The point is there are many kinds of idiopathic disorders. So interstitial lung disorders, known causes, 3 for this group. Connective tissue disorders, drug-induced, amiodarone, and third one is the occupational disorders. two granulomatous disorders, sarcoidosis and hypersensitivity pneumonitis. Then there is a whole group of idiopathic disorders. When we say idiopathic disorders, means we are not sure as to what started this. There are many idiopathic interstitial lung diseases, but we divide them for our discussion today into IPF, idiopathic pulmonary fibrosis, and the rest. And I focus on IPF for you today because of all the interstitial lung disease. IPF has the worst prognosis of all. Wake up now. Of all the interstitial lung disorders, IPF has the worst prognosis. I don't know if it pans up like this or not. During our lectures, we have talked about how we inhale disorders. Larger particles in the dust, if we inhale, they get lodged into the nose because nose has nasal mucosa and things like that. They trap it. When they trap it, they result in allergic rhinitis, inflammation in the nose. If the particle that you're inhaling bypasses the nose and lodges into the airways and lodges into the mucus of the airways, it will cause some inflammation. A good clinical example of that is bronchial asthma. Remember, we talked about bronchial asthma being an allergic process, CDTs, type 2, Th2 types of cells, and eosinophilia and things like that. Smaller particles, less than 5 microns. They can pass through the nose, you inhale, they pass through the lung, and they could lodge into the alveoli. From the alveoli, they're moved into the interstitium where they stay and cause a significant inflammation, and that results in interstitial lung disease. This is a good way of remembering. Of all the patients that you would see with pneumonia, 20% would be idiopathic pulmonary fibrosis, worst kind. 20% sarcoidosis. 20% hypersensitivity pneumonitis, and a mismatch of others. I just need to remind you, the one in red, connective tissue disorders, drugs, occupational sarcoidosis, and hypersensitivity pneumonitis are best initial treatment with steroids. The one in the red are best treated with steroids. Keep in mind, idiopathic pulmonary fibrosis is not treated with prednisone, and we have specific anti-fibrotic medications to treat this condition. Just to complete the picture, there are some rare causes as well. They are not important for this group, so let's just know that there are some rare causes, but that's very rare, not to be asked in the exam, not necessary for you to know. Same disease processes put together, a little bit more clinically relevant. As I said, known etiology, connective tissue disorders related to rheumatoid arthritis, scleroderma, Sjogren's, idiopathic inflammatory myositis, hypersensitivity pneumonitis, idiopathic pulmonary fibrosis, and sarcoidosis are more common. Connective tissue disorders, hypersensitivity pneumonitis, idiopathic pulmonary fibrosis, and others. The other ones, occupational, drug-induced, smoking-related, etc., are not that common. Common things occur commonly, and if you diagnose them commonly, you will commonly be right. Uncommon things occur uncommonly. If you diagnose them commonly, you will commonly be wrong. It's a profound statement, remember it. There are certain interstitial processes which occur more commonly, and 4 of these I gave it to you. Sarcoidosis, hypersensitive pneumonitis, collagen vascular disorder-related interstitial lung disease, and idiopathic pulmonary fibrosis. As we had talked about, that majority of the these disorders start with some kind of inhalation, leading on to inflammation. So the early part of any type of fibrotic process in the lung or in the interstitium is pro-inflammatory, has more inflammatory cells. As the disease progresses, inflammation becomes less and less and less, and fibrosis becomes more and more and more. Inflammatory processes, or where inflammation is more common, let's get back. Steroids would be helpful because steroids are anti-inflammatory. But as the disease processes becomes more fibrotic, because sarcoid and hypersensitivity pneumonitis, they both start as, and collagen vascular disorder disease, they start as inflammatory processes, but end up as fibrotic lung diseases in which the inflammation dies down and now collagen is laid down. These disorders would not be treated with steroids. They will require anti-fibrotic treatment, anti-inflammatory drugs, anti-fibrotic drugs. Keep that in your mind. When do we think of interstitial lung disease? Okay. Patients who have progressive shortness of breath and a mnemonic C, C, and C. Persistent dry cough, clubbing, and crackles. Persistent dry cough, clubbing, and crackles, if they are present, chances are your patient has interstitial lung disease. Dry cough, clubbing, and crackles, chances are you're dealing with an interstitial lung disease. Patients who have progressive loss of exercise tolerance, patients who have multiple medication intakes. Why do drugs cause interstitial lung disease? That should come as a news to you. It is because when we take a medicine, we take it in our mouth, it goes into the stomach, gets absorbed. From there, it goes to the liver, from liver into the hepatic veins to IVC. IVC takes it to right atrium, right ventricle, and then it comes into the pulmonary artery. Some of it seeps into the interstitium and causes an inflammatory reaction. In fact, all chemotherapeutic agents cause interstitial lung disease. Write this down. All chemotherapeutic agents have the potential of causing interstitial lung disease. The most common of them is busulfan or methotrexate. In general, drugs which accumulate into the lungs, and the best example of that is amiodarone, cause pulmonary fibrosis. That would be called as amiodarone-related pulmonary fibrosis. That can cause disorders, fibrosis in the lung too. So detailed history of occupations, detailed history of medication intake, and lastly, pets, whether you're exposed to dogs, cats, parakeets, pigeons, snakes, whatever you're breeding at your home, or you get exposed to, or you have an occupational hazard, you get exposed to the droppings of these birds and animals, and some of which you inhale. The droppings are micron, less than 1 micron in size. They go into the lung. Our neutrophil elastase, the proteolytic enzyme, is not able to dissolve it. They stay into the alveoli and then are moved by the type 2 macrophages into the interstitium, where they cause an inflammatory reaction. So we also take a history of pets at home in patients with interstitial lung disease. I've been saying that time and again, just to remind you, there are 3 areas of the lung where patient is short of breath, but chest X-ray may be normal. Asthma, early interstitial lung disease, and pulmonary embolism, 3 conditions in which patient is short of breath, but chest X-ray may be normal. So early interstitial lung disease, chest X-ray may be normal. I can't keep reminding you again and again. So patients with interstitial lung disease present with shortness of breath, dry cough, we have gone through this. Fine crackles, CCC, cough, clubbing, and crackles is the triad, which is specific for these things. These patients also can develop hypoxemia. Ultimately, they may also develop pulmonary hypertension or right-sided heart failure, which is a cause of death in these conditions. Yes, interstitial lung disease, just like COPD, can also cause pulmonary hypertension and right heart failure. Pulmonary hypertension and right heart failure. We have looked at these diagrams before. How do we study these patients? We look at their spirometries and PFTs. We did that already in interstitial lung disease. All 4 volumes are decreased. IRV is decreased, TV is decreased, ERV is decreased, RV is decreased, and that's a restrictive ventilatory problem. And further, if you look at these, their FEV1 by FVC ratios are preserved. Their FEV1 to FVC volume ratios are preserved, though FE1 is decreased, FVC is decreased, TLC is decreased, but FE1 by FVC ratio is normal. We have done this before already. Just to recap, interstitial lung disease versus obstructive lung disease. I've shown this slide to you before. Ignore the extrinsic one right now. FE1 is decreased in both. FVC is decreased in both. But the ratio of FE1 to FVC is decreased in obstructive lung disease. It is normal or increased in interstitial lung disease. Residual volume is increased in COPD asthma. It is decreased in interstitial lung disease. TLC is increased in obstructive lung disease, decreased in interstitial lung disease. Vital capacity is decreased, vital capacity is decreased. Functional residual capacity is increased in obstructive lung disease, decreased in interstitial lung disease. More importantly, diffusing capacity of carbon monoxide. Diffusing capacity of carbon monoxide is decreased in asthma, COPD. And in COPD, it is normal in asthma, it is decreased in interstitial lung disorders. So PFTs are helpful. What else do we do if you suspect interstitial lung disease? First, you do a chest X-ray. Early chest X-ray may be normal, and early ILD, chest X-ray may be normal. In those cases, we would do a CAT scan of the chest. It's possible the chest X-ray is normal, but the CAT scan is abnormal. What do we see in the chest X-ray? Once it is normal, when it becomes abnormal, what do we see? We see what these kind of markings. These are lace-like markings on the lungs. This is a chest X-ray. This can be linear. They can be reticular means, the curvilinear types. They can be nodular looking. Point is, there are markings in the lungs in late stages of fibrosis. Early fibrosis, chest X-ray is normal. Late fibrosis, there are linear shadow, reticular shadow, and nodular shadow. Linear shadows, reticular shadows, this is how it looks like. Nodular shadows. Then maybe reticulo-nodular. Mind you, this is very different from the consolidation that you see in alveolar disorders where we see an air bronchogram. I hope you people are awake right now and have looked at my first and second lecture when we talked about that in pneumonia, alveolar processes, congestive heart failure, you will see an air bronchogram. We do not see air bronchograms in interstitial lung disorders. What about the CAT scan of the chest? In fact, the best way to study interstitial lung disorders is to do a high resolution CAT scan. High resolution CAT scan produces very thin portions of the lung as sections, and you can look at the lung. And we can see in the lung something called a secondary pulmonary nodule. This is how it is, as you can see, complete this thing. Secondary pulmonary nodule is a anatomical functioning unit of the lung. In the center is the small bronchiole. Periphery is the lymphatics. The blood vessels are in there. The arteries come here, the veins at the periphery. So the periphery of the lobule is veins and lymphatics. Center of the lobule is the small bronchiole as well as the pulmonary arteriole. In patients with pulmonary fibrosis, this area becomes thickened. I've marked it with yellow. Let's see how. talked about the reticulations, and there are 4 features on CAT scan. These are the 4 features that you see on a CAT scan in interstitial lung disease. Now, people wake up, don't show up to the exam without knowing these 4 terms. We have introduced these terms before as well. In this case, as you can see, these linear opacities, thickened here, thickened here, thickened here. These are called as reticular markings. Reticular markings are the fibrosed peripheral part of the secondary pulmonary nodule. This portion gets more thickened. So you start seeing its reticulation. Are lace-like markings in the lung, just like you see it in the chest X-ray. Here you see in late stages, but even if the chest X-ray is normal, you will see reticulations in CAT scans. This is the trachea. These are the markings. You also see on a CAT scan ground glass appearance. Ground glass appearance. What is a ground glass appearance? Ground glass appearance is little grayish area on the lung. This is normal looking area. This is abnormal looking area. Increased haziness on the lung. Reticulations, increased haziness. Third thing, dilated airways. Dilated airways, these are here. We call that as traction bronchiectasis. Reticulations, ground glass, traction bronchiectasis. And lastly, you see some areas of destruction with cyst-like structures at the periphery of the lung called as honeycombing. Which are cystic air spaces in the periphery of the lung. First starts reticulation and ground glass. Then there is dilatation of the peripheral airways. And lastly, cystic areas, because of further destruction of the lung occurs, it's called honeycombing. So for CAT scan of the chest in interstitial lung disease will show any of these 4 changes, or they may all 4 be present or 3 may be present. Presence of honeycombing means patient has the very advanced disease, very poor prognosis, 1 to 2 to 3 years at the most survivability for the patient. So CAT scan tells you a lot more than a chest X-ray. We look at 4 things: reticulations, ground glass. We look at traction bronchiectasis and this. Please remember, consolidation air bronchogram is not part of interstitial lung disease. That represents alveolar filling defect like pneumonia, congestive heart failure, hemoptysis, etc. These 4 things, if you see it or read it on the report, you know the radiologist is talking about interstitial lung disorders. Okay. Same thing, reticulations are these lines. Late stages, you can see it on the X-ray as well. You can see reticulations on this also. These are result from thickening of the interlobular septa. Ground glass appearances, haziness, and increased opacity. These little cotton wool type of things are the ground glass appearance. This is also ground glass. There are many causes of ground glass appearance, but by far ground glass appearance presence generally indicates interstitial lung disease. Traction bronchiectasis, this is traction bronchiectasis, this is traction bronchiectasis, this is like the bronchi are pulled open. And this occurs because the surrounding lung is fibrosed. And lastly, honeycombing. These are the small cystic spaces at the periphery of the lung. Small cystic spaces at the periphery of the lung. They look like honeycombs, as you can see here. That's why it's called as honeycombing. On a pathology autopsy specimen, these are the cystic spaces in the periphery of the lung and very suggestive of advanced pulmonary fibrosis. I hope you've understood the 4 features on CAT scan that tell us patient has interstitial lung disorder. I've shown the slides already. The slides move from slides of the patient's fibrosis generally starts as inflammatory, more inflammatory cells, neutrophils or CD4 cells. Then slowly it becomes a little bit more and more fibrotic. Initial stages, we'll treat it with steroids, late stages with antifibrotic things. So you can see interstitial lung disease has many phenotypes, may be associated with occupations, medications. Hypersensitive pneumonitis is when you're exposed to products from animals and agriculture products. Autoimmune is collagen vascular disorders. There is some smoking related ILD as well. I do not want you to go away with the idea that smoking only causes COPD. Smoking can cause interstitial lung disease as well. Please remember it. Smoking can cause interstitial lung disease as well. We can take a biopsy of the lung, and looking at the cellular cells, we can divide it into further what kind of inflammatory cells are there. Or we can take the fibrotic part of the lung and biopsy it, and we can see where the fibrosis lies. But as you can see, once the fibrosis sets in, alveoli are all collapsed. There is hardly any alveoli left in this patient. That is why these patients are so hypoxemic. They desaturate on walking. So how do we evaluate? We think of C, and C. We think of chronic cough. We look at clubbing. We look at crackles. There are three things in the history. History are PETs, medication history, or features suggestive of collagen vascular disorder by asking for a history of rash and joint pains. So what do we do for our patients? We'll do some lab values. We'll do CAT scans. We ask for environmental history of joint pains for collagen vascular disorders, medication intake, job exposure for occupational. Rarely there's a family history of IPF, smoking, and some genetic conditions in which ILD is common. Okay. Once you have seen the patient and you decided this patient has interstitial lung disease, we try to figure out the cause. That's why three things in the history are important. History of medication intake, history of occupation, and history and features of collagen vascular disorders. Last one, we always ask history for birds, mold, etc. at home. If we are doubt, sometimes we're not clear, we would do lung biopsy. We do less and less of open lung biopsy because a lot of time with the detailed history, blood work, you are able to figure this out. PFTs showed decreased diffusing capacity of carbon monoxide, decreased spirometry with FeV1, FEC low with preserved FEC, FeV1 by FEC ratio. What blood work? I said it here. Immunological serology. We can send a lot of blood work, but three initial labs that you should send on your patient. Antinuclear antibodies, angiotensin converting enzyme, and hypersensitivity panel. Antinuclear antibodies, if positive, will tell you that this is a connective tissue or collagen vascular disorders. Angiotensin converting enzyme, if it is elevated, is probably sarcoidosis. And a hypersensitivity panel, if it is positive, kind of tells you that this patient's interstitial lung process is from exposure to some kind of protein, either from the animals or even from agricultural products as well. Hypersensitivity pneumonitis does occur in farm workers, etc., etc. Can we do bronchoscopy? It has little role, but sometimes it can help us biopsy and tell us what it is, what kind of fibrosis it is, but generally surgical biopsy, or nowadays we do a cryobiopsy, that's helpful. Taking the tissue, because it is associated with comorbidity, we try to avoid it if we can kind of make our diagnosis with history, physical exam, lab values, etc., etc. The treatment must be tailor-made, specifically per person. You have to make a specific recommendation for the patient depending upon the underlying disease, the cause, and its severity. certain things in general management should be obvious to us. Look for reflux, osteoporosis, depression, common comorbidities in ILD. Look for reflux treated, osteoporosis treated, depression treated. Patients are referred to the pulmonary rehabilitation. If patient is smoker, smoking cessation. Give them supplemental oxygen. Supplemental oxygen if they are hypoxic. Same way, if their saturation is less than 90%, they will be given oxygen. Oxygen is to bear 18 hours of the day. Then medications are either steroids or other immunosuppressive or antifibrotic agents. Steroids, immunosuppressive or antifibrotic agents. One more time, all patients are referred for lung transplant because this condition can be rapidly fatal. That's why all patients are referred for lung transplant as well. So the same diagram that I showed you, let's look at interstitial lung diseases, occupational collagen vascular disorders, idiopathic granulomatous, rare. Let's look at this and we'll see where we are with this. Occupational disorders, a history of occupation is important. And one common thing for the exam is history of asbestos exposure. In the past, we have talked asbestos causing pleural effusion, pleural calcification. We talked about diaphragmatic calcification, interstitial lung disease. Then it can cause some pleural mesotheliomas and even risk for lung cancer. That's why asbestos is important for the exam. In patients with asbestos-related lung disorder, if you do the sputum examination or bronchoscopy, take a sputum sample and send it for examination, they do have in the mucus called as ferruginous bodies. These are nothing but undigested asbestos fiber which patient has inhaled over the years. This is an autopsy specimen showing you the calcification of the diaphragm in a patient with asbestosis. Asbestosis is related, it can result in mesothelioma, everybody knows. Silicosis. Silica is used in a lot of electric material and house construction and things like that. Silica causes the eggshell calcification of the lung, as well as in those patients, there may be some upper lobe fibrosis. Eggshell calcification means the periphery of the lymph nodes in the mediastinum are calcified. That's very specific for silicosis. Similarly, farmer's lung, beryllium worker's lung, depending on what occupation, we call that interstitial lung disease due to that. And this list is more than 100 causes long. I will not want you to know anything except silica causes eggshell calcification, asbestos causes diaphragmatic calcification, something, because these are unique. Once we see that, we know the diagnosis is confirmed. What about the medications? This list is very long. And the one I gave you a good example is amiodarone, but any drug that patient takes for chronically for a long period of time can accumulate in the lung and causes fibrosis. It's possible. This is most commonly missed. So what is the management of drug-induced or occupational-related ILDs? Stop the inciting agent. Patient cannot go back to work. Stop the medications. Supportive care is oxygen, rehab, osteoporosis, depression, reflux treatment, etc. And these conditions sometimes may respond to steroids, What about collagen vascular disorders? Collagen vascular disorders are many kinds. And in this collagen vascular disorder, body forms antibodies against your own cells. And if it starts antibodies against the interstitium, starts attacking it, causing inflammation and fibrosis, you will develop interstitial lung disease. In fact, that happens very commonly in patients with scleroderma, dermatomyositis, SLE, rheumatoid arthritis, etc., etc. In these patients, the diagnosis is easy because they do have features of the underlying collagen vascular disorders like Raynaud's phenomena, sclerodactyly, typical mouth abnormalities, telangiectasia in scleroderma. In those patients, we can see on a CAT scan interstitial lung disease. Rheumatoid arthritis is also associated with interstitial process. It may be little reticulations, nice ground glass appearance, little traction, bronchiectasis, etc., etc. What is the management of interstitial lung disease related to connective tissue disorder? Recognize first, ANA would be positive, anti-nuclear antibodies are positive in these patients. You have to co-manage it with the rheumatologist. Supportive care is 3 conditions: treat osteoporosis, treat reflux, treat depression, pulmonary rehab, and oxygen. We start with steroids. In this condition, but because they need long-term steroids, it may not be possible. So we end up giving them other immunosuppressive therapies. Few of these immunosuppressive therapies are mycophenolate, methotrexate, cyclophosphamide, and rituximab. Mycophenolate, methotrexate, cyclophosphamide, and rituximab. Cyclophosphamide spelling needs to be changed. Ultimately, if they don't do well, they are referred for lung transplant. So you see, depending upon the underlying cause, the treatment is a little different. What about the granulomatous disorders? There are 2 granulomatous disorders for you: sarcoidosis and hypersensitivity pneumonitis. Sarcoidosis is a granulomatous disorder which involves the lymph nodes as well as the lung, but it can involve any part of the body. So it's a multi-system disorder. This is a multi-system disorder. It seems more common in African American population, younger, 20 to 40, 50 years of age. These patients may have skin involvement, skin rashes of scleroderma, of sarcoidosis. They may have eye involvement, they may have brain involvement, it can have liver involvement, it can have heart involvement. Sarcoidosis, which forms granulomas, can go anywhere. Sarcoidosis is associated with increased angiotensin converting enzyme. Treatment of sarcoidosis is steroids. If that fails, methotrexate, Plaquenil, infliximab can be used. Few words about the chest X-ray in sarcoidosis. You will see the mediastinal lymph nodes are involved, as well as there are opacities in the lung. Skin sarcoidosis causes erythema nodosum. If people remember it, I've mentioned this multiple times already, so it comes in the exam, that erythema nodosum can occur in sarcoidosis, coccidioidomycosis, pregnancy. It can occur in streptococcal infection, etc., etc. Sometimes sarcoid patients may have skin involvement on the face. This is called as lupus pernium. Sarcoidosis, I want you to remember 1/3, 1/3, 1/3. 1/3 remains stable, 1/3 progresses, 1/3 remits. Means over a period of time, it completely disappears. 1/3 persists, 1/3 remits, and 1/3 progresses to fibrosis. We divide sarcoid into multiple stages, not necessarily important. But here is a case of mine, as you can see. Initially, patients' changes are mostly in the lymph nodes and the mediastinum. That's why you see these hilar lymph nodes. Over a period of time, the lymph nodes kind of disappear or dissolve, become small in size, but reticulations are occurring in both the lungs. And another 7-8 years, you can see the same patient, the lungs have become small. Same patient, lungs have become small. She cannot take a deep breath in because they have lost lung volumes. This is a very good example of following a patient for 10 years. Sarcoidosis started in the mediastinal, hilar lymph nodes, then went into the lungs, then hilar lymph nodes disappeared, and then so much of fibrosis that the lungs became small. What about hypersensitivity pneumonitis? In this disease also, you get granulomas formation in the lung. This is a T helper cell mediated phenomena. Hypersensitivity pneumonitis is due to immunological reaction from antigens which you have inhaled either from animal products or agricultural products. Initially, it is inflammatory in origin. Ultimately, it becomes fibrotic. So this is also initially treated with steroids, but later on with anti-fibrotic agents. We divide it into acute, subacute, and chronic type, but as the disease passes. What are the antigens which cause hypersensitivity pneumonitis? Microbials like MAI can cause that, but avian with bird products, animal products, and less commonly organic compounds. These are basically agriculture products. Those who work in the cane sugar farms, those who go on in wheat and corn farms, they inhale things which can go into the lungs, cause an inflammatory reaction. And yes, they do develop hypersensitivity pneumonitis. I hope you appreciate when you get your food as to what those people are going through who have collected this for you from the farms. Since it is associated with fibrosis, there's a way to check for hypersensitivity pneumonitis, but most is to do a detailed history. Sometimes we can check, is patient sensitive to specific antigens? That's what's the hypersensitivity panel that I talked about. In these patients, lymphocytes are increased in the bronchoalveolar lavage. Treatment is steroids, immunosuppressive agents like methotrexate, like plaquenil, like Cellcept, and later on, anti-fibrotic agents. Okay. We looked at occupational disorders, steroids take away the agent. Collagen vascular disorders, steroids, immunosuppressive therapy. Granulomatous disorders, steroids, and then immunosuppressive therapy. What about the idiopathic interstitial pneumonias? Idiopathic interstitial pneumonias for today's discussion are IPF or non-IPF. IPF is more common and has worse prognosis. In fact, of all the interstitial lung disorders, IPF has the worst disorder. So how do we diagnose IPF? It's commonly in elderly population. You won't diagnose IPF in 30, 40 years of age. Remember patients with CCC, dry cough, dry crackles, etc., and clubbing, basilar crackles. Patients had usually more than 50, slowly progressive course. Okay. This is the chest X-ray of an IPF patient's idiopathic pulmonary fibrosis. Generally, the disease is more common at the basis than at the apices. It is associated with these cystic spaces, honeycombing at the basis, along with these irregular lines, which are reticulations. These little holes, which are much bigger here, are the honeycomb cyst. They've seen in a different way. IPF is a lower lobe predominant, not upper lobe, lower lobe predominant process. And it starts from the periphery of the lung and moves center. You can see it's at the periphery of the lung and then slowly moves into the center. In biopsy, it is heterogeneous in origin, means certain alveoli are preserved, but others are completely destroyed. It is rapidly progressive and fatal. On biopsy, we see something called as usual interstitial pneumonia, in which we see a fibrotic foci, a nodule like this. That is very definitive of this. Nobody's asking you pathology on the exam, but you can see this is a normal looking lung, and this is the interstitium in between. Here, the interstitium is all fibrosed, the alveoli are collapsed, and the fibroblastic foci is the place where there's more fibrosis is being laid down, and then that it's moved to the other areas in the interstitium. Diagnosis of IPF, CAT scan, lower lobe predominant, peripheral in an elderly population with ANA negative, ACE level negative, hypersensitivity panel negative. That's how we see it. It starts with, it can have a very rapidly fatal course, and within 1 year, the patient is dead. Or it may go for 3, 4, 5 years, but 50% of patients will not be with you in 4 or 5 years. That's a profound statement. That's why I'm spending so much time on this. And just like COPD, asthma, bronchiectasis, if they get an exacerbation, they become more severely sick, more short of breath, they deteriorate, and they never return back. So exacerbation of ILD is equivalent to a massive MI of the lung. They hardly ever recover. Ultimately, these patients are on 24 hours of oxygen. Then they become lung crippled, means they are in a wheelchair, 24/7 oxygen, poor quality of life, and continue to deteriorate. Patients with any kind of fibrosis develop pulmonary hypertension. Please note this. I also want you to know, for the sake of record, that any kind of fibrosis is a risk factor for lung cancer. Any kind of fibrosis is a risk factor for lung cancer, and I hope you people know that. We go through certain calculations in our mind: higher the age, lower the lung functions, and we give them scoring. That scoring is not for exam, it's not for you, but this is to give an idea how we kind of standardize the severity of the disease. Age of the patient, males do poorly, and then functional capacity of FVC and FEV1 and things like that. Certain comorbidities are common in ILD, and please don't show up on the exam without knowing this. I would be very, very unhappy. Patients with ILD have a high incidence of coronary artery disease, high incidence of pulmonary embolism, high incidence of bronchogenic carcinoma, high incidence of GE reflux, and high incidence of pulmonary hypertension. What are the risk factors for progression? Higher the age, 70 years will do much poorly as compared to 50. Males have a poor prognosis. Higher the level of dyspnea. If patient was a smoker, chances are disease will progress very fast. If patient's bronchoalveolar lavage show a lot of neutrophilia, there may be chances that this patient's inflammation is so intense, it's not going to respond. Based on the biopsy results, bronchoalveolar lavage results, autoimmune processes, lung functions, CAT scan, you come up with a multidisciplinary team and management. This slide is specific for the idiopathic pulmonary fibrosis patients. Idiopathic interstitial pneumonia are also included here. What is the supportive treatment? Immunization, pulmonary rehab, reflux, osteoporosis, depression kind of things. Oxygen therapy, oxygen's crucial. Now, please remember, in these patients, we use different kinds of medication. That's why I will ask it in the exam, because I want you to know these meds. These are not steroids, these are not immunosuppressive agents. This is two medicines, rather three at this point of time. Pirfenidone, its mechanism is not clear, but it is an antifibrotic agent. And nintedanib, which is a triple kinase inhibitor. And the third one is nerandomilast. Jascade is the name. Pirfenidone, nintedanib, nerandomilast. It's fair game on the exam to ask what are the antifibrotic medications that we use for pulmonary fibrosis. Pirfenidone, nintedanib, and nerandomilast. Why is it important to know? Because if you go to the hospital and you're in the clinic rotation, I don't want you to stand there and not know what the hell the doctor and the other healthcare people are talking about. So for idiopathic pulmonary fibrosis, treatment is slightly different. We do antifibrotic medications. We do not use steroids. We do not use immunosuppressive agents. Lung transplant is an option for all our patients, And those patients, if these medications don't work, would need lung transplant. We have a very active lung transplant program at my hospital as well. And I've had a number of my patients who have had lung transplant done because they were not responding to medications. So what about acute exacerbation of interstitial lung disease? That's the time when patients become more short of breath. What is the definition? Acute exacerbation of IPF is known diagnosis of IPF, worsening dyspnea, new opacities show up in the lung. Known diagnosis of IPF, worsening dyspnea, just like the exacerbation in asthma and COPD. And here, new bilateral ground glass opacities show up in the CAT scan. Mortality is 50%. And mortality is 50%. This is one of my patients. As you can see, he's intubated these trachea. Here, 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 here. All the entire lung is now involved. Very poor prognosis. Exacerbation is treated a little differently. Here we will continue the antifibrotic treatment, but we will give high doses of steroids. Here we will continue the antifibrotic treatment, we'll give you high doses of steroids. We may use other medicines as well, including extracorporeal membrane oxygenation. Needless to say, most of these people get intubated. So the summary of IPF is a form of idiopathic interstitial pneumonia, worse prognosis. It is more common in 50 plus, more common as the age progresses, has very poor prognosis, does not respond to steroids. It responds to antifibrotic treatments. 3 medications to be used are pirfenidone, nintedanib, and nerandomilast. So I have given you a kind of a brief overview of what interstitial lung disease is. We divided into known causes, granulomatous disorders, idiopathic type, and I subdivided as to what is the treatment of each and every one of these. Any question? And we looked at the ILD exacerbation as well. Any questions at this point of time? As I said, if there's no question, either if people understood everything or they tuned me out and understood nothing. I want to believe the first one. Some of what I've taught today was reviewed before in terms of X-ray, CAT scans. Even I talked about these findings, these 4 features of ILD on CAT scan, chest X-ray, and things like that. We have also reviewed the PFTs before. So hopefully this lecture was not that heavy. Will there be X-ray on the exam? No, I'm not teaching you X-rays. I'm not teaching you how to read X-rays. I'm just giving you a flavor of what it is. Does the smoking of interstitial lung disease increase lung cancer? Yes, it does. Are we in person tomorrow or Zoom? I think we will be on Zoom because I think it's in the afternoon. It's tough to get there, and I have a case which, if it goes long, I won't be able to get there. So as of now, presume it is on the Zoom. We still have time. I'm gonna take 5-minute break. What's the time right now, people? It's 6:37. Let's come back at 6:45 and we'll continue with the next lecture, which is the pulmonary hypertension. I'll stop sharing my screen. I will be back with you people at 6:45.
Professor, would it be possible to send me the pulmonary hypertension slides?
I'm sorry, does everybody have the lectures?
Yeah.
Okay, can you then start then, okay? Without wasting any more time, let's get this going. So up till now, we have talked about some disorders and we have fair amount of idea as to how to deal with these kind of disorders. As you can see, something which looks very simple is not obviously that simple. And when you look into it, there are many aspects to a disease process. And as a clinician, as a healthcare provider, you want to look at a patient, take history, physical exam, ancillary test, and make up a plan, which in terms should be helpful to the patient. And that's what we're trying to learn through all these lectures. So let's look at the other next. The pulmonary embolism is being covered by, I think, Mike or whoever is doing it. So I will take the pulmonary hypertension. What is pulmonary hypertension? Pulmonary hypertension essentially means high pressure in the pulmonary circulation. Simple, high pressure in the pulmonary circulations. Let me put it this way, so maybe it's a little bit more easier for us. Okay. So as we know, the lungs have two blood supplies. One is the pulmonary circulation, and the second one is the bronchial circulation. We touched upon the bronchial circulation when we were talking about hemoptysis, and we learned that the hemoptysis is always from bronchial circulation, never from pulmonary circulation. Then we changed gear, and when I was doing physiology and gas exchange in my second lecture, we looked at how the pulmonary artery takes the blood, gas exchange, then to the left atrium, left ventricle and through the entire body, then through the IVC and SVC system, blood comes back to the right atrium, right ventricle, and pulmonary circulation. Easy to understand. We have done this. There is, just for your knowledge, little bit of connection. Bronchopulmonary anastomosis do occur in the lungs once in a while. I do not want you to go away with the idea that the bronchial arteries basically supply the bronchi and the alveoli, whereas the pulmonary artery is supplying the alveoli. And it's not supplying, but it's actually covering the alveoli so that the gas exchange can occur. And interestingly, there is a bronchopulmonary anastomosis. That is why if one circulation is completely obliterated, sometimes the other one will still be functioning in that area of the body. The gas exchange would be poorly done, but the alveoli will still be surviving. So this kind of connection between the bronchial and pulmonic veins, the bronchial veins do contribute to some kind of deoxygenated blood to the pulmonic veins, which take it to the left atrium. This circulation is not clinically significant, but you see there is one way to get a little bit of deoxygenated blood in the pulmonic veins, which take it to the left atrium. This circulation, these connections are never that clinically important. So we can ignore it for now. Let's focus on the pulmonary circulation. What is pulmonary circulation? Pulmonary circulation is a low pressure, low resistance circuit. Low pressure, low resistance circuit. One more time, low pressure, low resistance circuit. The pressure in the pulmonary artery is around 15 millimeters of mercury. Mean pressure in the pulmonary artery is around 15 millimeters of mercury. 15 millimeters of mercury. Pressure in the systemic vessels, aorta, is around 90 millimeters of mercury. So pulmonary pressures are 1/6 of the systemic pressures. But at the same time, our pulmonary artery is very pliable. It can dilate and contract. It can accept more blood volume and less blood volume depending upon the venous return. So the resistance of the pulmonary artery is very low. But if this artery becomes stiff, this pliable vessel which can open up and then close, if it becomes by stuff like this, the resistance in the pulmonary artery will increase. And that will result in high pressure in the arteriolar system. When that happens, the gas exchange will be impeded and patient will be short of breath. That is the connotation of pulmonary hypertension. To recap, pulmonary circulation is a low pressure system, 1/6 that of the systemic circulation. The pulmonary vessels are pliable. They can dilate and contract at the same time, depending upon the venous return. But if pulmonary vessels become stiff, the pulmonary vascular resistance and pulmonary pressures in the pulmonary artery will increase. That would impede gas exchange and patient will be hypoxemic. Just to recap, if you take a heart and cut it, take the heart and cut it like this, you're left with the dominant left ventricle and a small parchment-shaped right ventricle. This is how the heart is in all of us. If you're healthy and no medical problem, left ventricle is a bigger dominant chamber, right ventricle is smaller because the pressure in the left ventricle is 6 times that in the RV. But if patient's blood flow is impeded, pulmonary vessels have a high resistance, right ventricle has to work harder. It has to work harder, it starts to dilate. If it starts to dilate, it results in this kind of structure. Now, RV is more dilated. If it is dilated, it pushes the septum into the left ventricle. Instead of here, it pushes into the left ventricle. So the left ventricle stroke volume will decrease and patient will also have systemic hypotension. Pulmonary hypertension can decrease the left ventricular stroke volume at some point as it becomes worse. and decrease the systemic pressure as well. Patient will be hypotensive, can have syncope as well. So this is normal looking heart. This is the heart of a patient who has pulmonary hypertension. So what controls the tone of this vessel? Three things: hypoxemia, nervous system, and neurohormonal control. Very interesting. Hypoxemia causes pulmonary vessels to constrict, systemic vessels to dilate. Remember that. Whenever they will call you for patients having low oxygen, ultimately patient goes into shock, means systemic pressures go down, but the pulmonary pressures are up. Hypoxemia has a paradoxical response. It causes pulmonary vascular resistance to go up and systemic vascular resistance to go down. Lungs are supplied by the vagus nerve, the cholinergic drive. We learned the cholinergic drive, how it affects the acetylcholine causes bronchoconstriction in COPD. We learned that. Similarly, the vagus nerve has some control on the blood supply, on the vascular tone of the pulmonary circulation. And thirdly, something very interesting, the pulmonary artery produces sometimes some substances. It produces substances if it wants to upregulate vasoconstriction or downregulate and cause more vasoconstriction, vasodilatation. So pulmonary artery controls its own tone. Of the three, the most important is the neurohormonal control of pulmonary artery dilatation and constriction, which is a very important concept for pulmonary hypertension. Yes, hypoxemia will cause vasoconstriction, and it becomes important in patients with severe COPD, ILD, etc. Now you realize why I kept on saying severe COPD will result in pulmonary hypertension, severe ILD will result in pulmonary hypertension. Now I hope it's clear, because both those conditions cause hypoxemia. Hypoxemia causes constriction of the pulmonary vessels, so pulmonary hypertension occurs. And if pulmonary hypertension occurs, patients die of right heart failure. The right ventricle becomes more and more dilated. Patients. This, in short, is a cartoon of a normal heart. If you look at the right ventricle, above is the right atrium. The right ventricle drains into the pulmonary circulation. Mean pressure of the pulmonary circulation's mean is around 15 millimeters of mercury. If there is problem in this circulation, means they constrict and the pressure starts to increase. Your right ventricle will have a higher pressure. It will dilate. If it dilates, if the RV dilates, the tricuspid annulus dilates. If tricuspid annulus dilate, there is tricuspid regurgitation. So even of those people who are sleeping in the class right now, tricuspid regurgitation means pulmonary hypertension. Wake up, it'll come in the exam. Tricuspid regurgitation means right ventricular dilatation secondary to pulmonary hypertension. When that happens, the TR, patient has to have tricuspid regurgitation, then pulmonary right atrial dilates. Right atrium dilates, back pressure, the IVC dilates. The IVC dilates, the liver, which is connected to the IVC through hepatic veins, that gets congested. Patient is hepatomegaly, they get some little bit of ascites. And as IVC gets more and more dilated, you start getting pedal edema. These are the features of right heart failure. RV dilatation, tricuspid regurgitation, right atrial dilatation, IVC dilatation, hepatic congestion, ascites, and pedal edema. People, I don't want you to just blindly remember things. I want you to understand. So pulmonary hypertension results in right ventricular failure, which results in TR, tricuspid regurgitation, can result in hepatomegaly, ascites, and pedal edema. Same concept I've talked about. A little bit of physiology. What determines the blood flow in a pipe? The pipe can be aorta, and the pipe this time is pulmonary circulation. Pulmonary circulation, blood flow is determined by the pressure between the incoming pressure and the outgoing pressure, depending at the inside and the outside. The two pressure difference between the end of the tube divided by the resistance. So flow, which is delivered by the Q, as the connotation is by standard, is equal to pressure difference between a tube divided by its resistance. Let me write it down. Delta P, which is the pressure difference, divided by the R. If you have a little bit of mathematical background, I'm sure you all have, because all of you went to high school and they teach you there at that point. If I take R on this side and bring Q on this side, resistance of pulmonary artery is equal to the difference in the pressures at the opening at the end of the pulmonary artery divided by the flow. This is very much similar to the Ohm's law, whereas voltage is equal to IR. I is the current, R is the resistance, or resistance can be V over I, which is voltage, over current is the resistance. Are you all with me? Delta P, I can replace Q by the cardiac output, which is the flow, is R. Delta P is equal to R into Q, or cardiac output multiplied by the pulmonary vascular resistance, or pulmonary vascular resistance can be delta P over cardiac output. Few more things about pulmonary, any resistance in any vessel. I don't want you to remember the formula. I want you to know the resistance of any tube, whether it is ureter, whether it is common bile duct, whether it is pulmonary artery, whether it is aorta. Resistance is inversely proportional to the radius to the power 4. As the radius becomes smaller, the resistance increases to the, and its relationship is R is equal to inverse to the power 4. Rest all are standard numbers, don't remember. This is described by the Pausilius equation. No need to know this, but today we need to know that a small change in the diameter of a blood vessel can have a significant impact on the resistance of that vessel. Okay, let's put all these things together. I said voltage, current, and resistance. Delta P is equal to cardiac output, which is the Q and the PVR. What is this delta P? Let us define it. This delta P is the mean pulmonary artery pressure minus the left atrial pressure. Think of this way. The blood flow from the pulmonary circulation, and then it starts to go into the left atrium. The pressure in the atrium, if it is high, it prevents the blood flow coming into it. So that is the end pressure. So delta P of the lung is mean pulmonary artery pressure minus the left atrial pressure, also called as pulmonary arterial wedge pressure. This delta P by convention is called as transpulmonary pressure. Transpulmonary pressure, which determines the forward flow of the blood from the pulmonary circulation into left atrium, is mean pulmonary pressure minus the left atrial pressure. And if you divided it by the cardiac output, you will get the pulmonary vascular resistance. Pulmonary vascular resistance. Transpulmonary pressure is mean pulmonary artery minus the wedge pressure of the left atrial pressure, and pulmonary vascular resistance is this divided by the cardiac output. Okay. All right, so delta P is pressure in the pulmonary artery minus pressure in the left atrium equal to cardiac output into PVR. I hope nobody's lost me here. TPP is cardiac output into PVR, so we replace TPP by the MPA minus pulmonary wedge pressure. So pulmonary artery pressure is a product of cardiac output, pulmonary vascular resistance, left atrial pressure. This is how I think of this. Am I asking this equation in the exam? No. Do I want you to understand it? Yes. Do I think students remember it? No. I know that. There's a little bit of physiology. It's hard to conceptualize. But the fact that pulmonary vascular resistance will shoot through the roof once pulmonary artery constrict, that is fair game. It is R to the power 4, and everybody should know it. Okay? And if this PA pressure increases, is either the cardiac output is increased, pulmonary vascular resistance is increased, or left atrial pressure is increased. Just 3 causes of this. Pulmonary cardiac output is increased, pulmonary vascular resistance is increased, or pulmonary left atrial pressure is increased. Same thing put together. This is the pulmonary artery leading into the left atrium. PA is the incoming pressure. PLA is the outgoing pressure. P pulmonary artery pressure is PLA plus cardiac outlet into pulmonary vascular resistance. So PA pressure goes up whenever there's vasoconstriction, obstruction of this vessel, and it decreases whenever this artery will dilate. Easy to remember. PA pressure will increase if there is vasoconstriction. It will decrease if it is vasodilatation. We can look at pulmonary hypertension in many different ways. Pulmonary high vascular resistance is either due to cardiac output is increased. This occurs in ASD, VSD, PD. A cardiologist should be teaching you that. Or pulmonary vascular resistance is increases, which is what we are talking today. Or left atrial pressure is increased. Just for fun's sake, left atrial pressure is increased in patients with left-sided heart failure. Congestive heart failure people all have left atrial pressure elevation. If that's elevated, your pulmonary pressure will increase. This is called as secondary pulmonary hypertension to left ventricular disorders. Okay, let's put this all mumbo jumbo physiology that I'm talking about. We all want to agree that pulmonary vascular resistance, increased pulmonary artery pressure will cause stress on the RV wall. Ultimately, it will fail. Patients will have massive edema, ascites, congestive hepatomegaly. Their patients' gas exchange is impeded, and patients will be hypoxic. So patients with pulmonary arterial hypertension die of right ventricular failure. Patients with pulmonary artery hypertension die of right ventricular failure. What is the definition of pulmonary artery hypertension? I said the mean pressure in the pulmonary artery is 15 millimeters of mercury. For pulmonary hypertension to occur, the mean pressure should be more than 20 millimeters of mercury. Now, this is fair game. You must know the definition of pulmonary hypertension, and it will be on the exam. Mean pressure, more than 20 millimeters of mercury. Now, whether this pulmonary hypertension is from left atrial causes or lung causes. This is the lung, this is the left atrium, this is the cardiac output state, which is ASD, VSD, PD is atrial septal defect, ventricular septal defect, patent ductus arteriosus. These are rare causes. Ignore them. Elevation pulmonary artery pressure, either there is direct increase in pulmonary vascular resistance, pulmonary artery has constricted, or there is left atrial hypertension or elevation in left atrial pressure. If it is in the left atrial pressure is increased, it is called as post-capillary process. If just the pulmonary vessel is constricted, it is called as pulmonary pre-capillary process. Pre-capillary process, post-capillary process. So pulmonary hypertension for today's discussion, and don't lose sleep over it, it's not that difficult. Pulmonary hypertension is mean pressure more than 20 millimeters of mercury. If the problem lies specifically to the pulmonary circulation, the wedge pressure will be less than 15. Wedge pressure is a reflective of left atrial pressure. And if problem occurred in the left side, the wedge pressure will be more than 15 millimeters of mercury. Inbuilt into this is that the pulmonary vascular resistance is more than 3 Woods unit. Okay. So mean pressure more than 20. If it is pre-capillary, more than 20 with less than 15 of wedge pressure, and resistance more than 3 Woods unit. Let's look at it clinically. How does these elevation in the pulmonary circulation occurs? Work with me. If I have a left ventricular problem, systolic function means heart failure with reduced ejection fraction. Diastolic dysfunction means stiff left ventricle, or I have a valvular heart disease. 3 causes. The LV doesn't do its job. The forward flow in the aorta is impeded. So jet actually hits the left atrium. There is elevation in the left atrial pressure. There's back pressure in the pulmonic veins, back pressure into the pulmonary artery, and you get RV dilatation. That's how left ventricular dysfunction result in RV dysfunction. This is called as biventricular failure. And fancifully, cardiologists call that as congestive heart failure. I hope you know this. So congestive heart failure is also a type of pulmonary hypertension, but in this, pulmonary hypertension is secondary to left ventricular problem. Three main left ventricular problems are heart failure with systolic decreased ejection fraction, heart failure with preserved ejection fraction, and valvular heart diseases. Then there are a group of patients with LV is normal. Their lungs are defective. COPD, ILD, kyphoscoliosis, three of these. COPD, ILD, kyphoscoliosis. These patients become profoundly hypoxemic as time goes on. You and I just learned that hypoxemia will cause vasoconstriction. If it causes vasoconstriction, pulmonary artery pressures will increase. Your RV will have to work harder. It will dilate. So now you know, second cause of pulmonary hypertension is severe lung condition. Three severe lung conditions are COPD, interstitial lung disease, kyphoscoliosis. Now, there are a group of patients who have no LV problem, no lung problem. They are hypercoagulable. We know 3% of the population has hypercoagulability on genetic basis. They develop clots in their legs. If they develop clots in their legs, some of these clots in the IVC move through the IVC and go into the right atrium RV and lodge into the lung. That's called as pulmonary embolism. Now, pulmonary embolism generally, with or without treatment, gets resolved. But if you get multiple PE episodes, your pulmonary capillary beds will be obliterated. If they are obliterated, there's no more blood flow going on because now it is obliterated. Pulmonary pressure increases, RV dilates. This condition is called as chronic thromboembolic disease. So we learned three types of pulmonary hypertension: LV dysfunction, lung dysfunction, and thromboembolic disease. There is a rare group of patients who have primary damage to the pulmonic veins. I will not discuss that today because that's a rare group of disorders, Beyond the scope of this class, less than 2,000 cases total described in the literature, so it's not important. You probably will pass your life without seeing one case, okay? These are rare causes. Let's ignore it. Then there are a group of patients who have no LV problem. LV is working fine. Their lungs are fine. They don't have fibrosis. They don't have COPD. They don't have kyphoscoliosis. They don't have any thromboembolic disease. But their pulmonary arteries begins to constrict. And in those patients, slowly the RV is working harder, dilate, and they start developing ascites, pedal edema, and right heart failure, and suddenly they die. That is called as, used to be called as idiopathic pulmonary hypertension. Today we call that as pulmonary arterial hypertension. Pulmonary arterial hypertension. So folks, if I say PH, pulmonary hypertension, I must qualify which group, which type it is. But if I say PAH, pulmonary arterial hypertension, PAH, pulmonary arterial hypertension, I'm referring to that group of patients where the pulmonary artery idiopathically is vasoconstricting, resulting in right heart failure. So pulmonary hypertension is the big group. It has 5 causes types. Pulmonary arterial hypertension type, in which primary damage to the pulmonary artery. Heart condition, 3 of those. Lung damage, 3 of those. Rare causes, a few of these, but not important. And pulmonary arterial hypertension. So we divide this into group 1, 2, 3, and 4, and 5. Group 1 is idiopathic pulmonary hypertension or pulmonary arterial hypertension. Group 2 pulmonary hypertension is those patients who have LV dysfunction. Group 3 PAH is those who have lung condition. Group 4 PAH are those who have thromboembolic dysfunction. And group 5 are rare group of causes. I hope it is clear. Hemodynamically, I did talk to you about this a while back. Look at this. This is the venous capacitance. IVC, draining into right atrium, right ventricle, pulmonary artery, pulmonary capillaries, pulmonic veins, left atrium, left ventricle, into aorta. This is one circuit. If the problem lies here, then LA pressure increases. It's called as post-capillary PH, post-capillary pulmonary hypertension. If the problem is directly damaged to the pulmonary artery, it's called as pre-capillary process. PAH, chronic thromboembolic disease, lung condition, and all these are pre-capillary processes because there's direct damage. Only left ventricular problems are the post-capillary processes, pulmonary hypertension. So PH can be divided into pre and post-capillary also, or it can be divided into the 4 groups, group 1, 2, 3, 4. Group 1 is PAH, group 2, heart condition, group 3, lung condition, group 4, chronic thromboembolic disease, group 5, veno-occlusive diseases are rare causes. Same group. When there is primary damage to the pulmonary artery, it is PAH. When it is heart, it is group 2. When it is lung, it is group 3. When there's obstruction to the pulmonary arteries through clots, it is group 4, and rare is group 5. Let's focus on PAH. PAH is also many kinds because it results from many things. It can be heritable, means patient has a family history of PAH. These are the patients who will give a family history of sudden death in my family in a young person. Nobody knows the cause. That's how generally it is. Yes, it does happen. I've seen it. Then there is a group of patients who have heritable because there is a gene which codes for angiogenesis of the endothelial lining of the pulmonary circulation. And if it is dysfunctional, these patients in their age, 30, 40 years of age, will start developing pulmonary artery vasoconstriction. PAH, people, wake up, occurs in young people, 30, 40 years of age. It is 7:1, more common in females. And it results in right heart failure, can result in sudden death. It's all preventable. That's why we are talking about it. These patients have shortness of breath. Everything else on paper looks good. They have pedal edema. They have ascites. They have enlarged liver. They have tricuspid regurgitation murmur. They have loud pulmonic component of the second heart sound. What else does it occur in these patients? What else causes this? Very similar. Connective tissue disorders, SLE, scleroderma, rheumatoid arthritis. Just like interstitial lung disease, these can cause pulmonary arterial hypertension. HIV infection, if you remember, I've been telling multiple times that HIV virus lives in the lung. It causes COPD. It causes infections like PCP pneumonia, but it can cause lung cancer. And now we know it can cause pulmonary arterial hypertension as well. Patients with liver disorders, they can have pulmonary arterial hypertension. And other rare causes, congenital heart diseases, schistosomiasis seen in Africa, not here, can cause pulmonary arterial hypertension. So many types. Pulmonary arterial hypertension is like a syndrome. It can occur. It can be heritable. It can be drug-induced. It can be connective tissue. It can be HIV. It can be portal hypertension. It can be schistosomiasis. I didn't want you to think that drugs don't cause it. Some of the medications do cause PAH as well. I'll spare you the number, those things. They are usually anti-cancer agents. Just like they cause interstitial lung disease, they can cause pulmonary arterial hypertension as well. Okay, we learned this already. Group 1 is idiopathic, 2 lungs, 3 COPD, 4th blood clots, 5th rare. Let's look at the features of heart failure. Heart failure can be left heart failure or a right heart failure, and I hope, and I do sincerely hope, and I really do sincerely hope that the cardiologists are drilling down into something basics for you, because every time I have to do this. Patients with heart failure have fatigue, dyspnea, palpitation. They have paroxysmal nocturnal dyspnea. They also have weight gain because they have pedal edema. These features are common to right and left heart failure. But patients who have pure left heart failure and who have secondary pulmonary hypertension, they have paroxysmal nocturnal dyspnea. They have orthopnea. They lie down, they feel more short of breath. They have crackles, and they have the very nice third heart sound, S3, on auscultation. Okay. Treatment of this is diuretics, control the blood pressures, ACE inhibitors, pacemaker placement, bypass surgery, heart transplant, what have you. I'm going to stay away from that. That's I hope is already been taught or being taught. But patients with pure right-sided heart failure, where LV is problem, left atrium is normal, these people still have jugular venous distension because right atrium is dilatation. They have hepatomegaly, they have peripheral edema. Generally, they do not have that much crackles in the lung. Yes, pure right heart failure patients have pulmonary vessels constricted. The fluid doesn't go into the alveoli, so they don't have crackles. That's one big difference between left and right heart failure. Okay. So pulmonary artery pressure results as PAH, results in right heart failure, more common in females and a younger age group. Whether it is congenital heart disease, whether it is idiopathic, it is collagen vascular disorder, HIV related, as you can see, 50% survival can be very poor in this group of patients. What I'm trying to say is, even with the best treatment today, PAH survivability is not that great. Why does it occur? Pulmonary artery is a nice pliable vessel, has an adventitia media and an intima lined by the endothelial lining. Endothelial lining becomes dysfunctional. Endothelial lining produces some enzymes to cause vasodilatation when it wants to dilate. When it wants to vasoconstrict, it produces some other materials, enzymes to cause vasoconstriction. If it starts producing more vasoconstriction and less vasodilatation, you will have pulmonary hypertension. First, there is vasoconstriction. Then there is inflammation and endothelial remodeling. Now, nice, as you see, the diameter of the vessel is decreased. You and I already learned the resistance is R to the power 4. Ultimately, the entire pulmonary vessel is obliterated. Patient results in right heart failure. So we believe initial stage is vasoconstriction. At that time, the disease is reversible. But with vascular lining, endothelial lining becomes dysfunctional. It produces, starts to proliferate. Ultimately, it proliferates like this. It starts producing less nitric oxide, less prostacyclin, and more endothelins. Endothelins cause vasoconstriction, and these cause vasodilatation. Nobody's asking this pathophysiology on the exam. It's more for you to understand that PAH is a disease of pulmonary artery lining, where the pulmonary artery lining starts producing vasoconstrictors, so it starts to constrict on its own. Early, the disease may be reversible. Late stages, it is irreversible. So what do you want to do? If it is vasoconstriction, do vasodilatation. If it is proliferation, give them anti-proliferative activity. And because ultimately, when the blood flow is impeded, in situ clots can occur, give them anticoagulation. We look at these products. In PAH, pulmonary artery lining produce more endothelin 1s, less prostacyclins and nitric oxide. These are the enzymes which nitric oxide synthase, prostacyclin synthase. If they're upregulated, it causes vasodilatation. So where are we? We still at pathophysiology. There is nice vessel. There is nice vessel vasoconstriction, vascular remodeling, so vessels destroyed and in situ thrombosis. So the treatment is, if it's vasoconstriction, give vasodilatation. Vascular remodeling, give anti-remodeling medicine. And if it's in situ thrombosis, give anticoagulation. On examination, these patients have shortness of breath. They may have syncope. Syncope means the RV is so dilated that is compressing the LV. Patient has 6 months to live. 6 months to live. They may have tricuspid regurgitation murmur on exam. They may have loud pulmonic component of the second heart sound. They may have Raynaud's, sclerodactyly from scleroderma, and things like that. As the PA pressure starts to increase, initially patients able to compensate with increased cardiac output, so PVR remains normal. If PA pressures increase and the cardiac output increases, vascular resistance remain normal. But a time comes when the cardiac output is not able to increase, suddenly the pulmonary vascular resistance starts to shoot. The right ventricle starts to dilate, and then they have decompensated right heart failure. This is nice pulmonary artery. It starts to become thickened, obliterated. In the end, it is completely obliterated. So how do we work up our patient belief? Echo is a screening tool, and right heart catheterization is the way to diagnose this. One more time, it will come in the exam. Echo is a screening tool to screen for PAH. The confirmatory test is right heart catheterization. Right heart catheterization. So we do echocardiogram, we'll do a whole bunch of parameters. We measure BNP in these patients. We do clinical assessments. We do right heart cath to look at right atrial pressure, cardiac output, and things like that. So multiple ways of looking at it. Echo is a screening tool. Hemodynamic evaluation through right heart catheterization is the gold standard test for confirming the diagnosis. EKG in these patients may show right bundle branch, incomplete right bundle branch block pattern because they have right ventricular hypertrophy. Chest X-ray in PAH may show enlarged pulmonary arteries. Enlarged pulmonary arteries, as you can see, large. On echo, this is an apical four-chamber view. The right ventricle is bigger than the left ventricle. What did we learn today? Left ventricle has a higher pressure. So LV pressure is higher than the RV pressure. But in these cases, the right ventricle has higher pressure. The septum is shifted to this. Right atrium is bigger than the left atrium. So echo is a good screening tool. We can look at the echoes and measure tricuspid regurgitation in many different ways. The confirmed diagnosis is right heart catheterization, and it will be on the exam because I want you to know, don't start treatment and don't give a diagnosis of PAH, which is quite a serious diagnosis based on an echo. You have to have a right heart catheterization. Right heart catheterization helps us divide whether it's a pre-capillary process or a post-capillary process. In the post-capillary process, pulmonary artery wedge pressure is more than 15. It means it's a left ventricular problem. Treatment is ACE inhibitors, beta blockers, rhythm control, pacemaker, bypass surgery, valvular heart surgery, transplant, and what have you. If the PA pressures are more than 20 and wedge pressure is less than 15, you have a problem primarily in your pulmonary artery. And that's a serious issue for our patients. So what do we want to do? We want our patients walk distances, exercise tolerance, and improve their pulmonary artery pressures should come down. Here are the treatments that we give. Specific treatment, very similar to ILD. Give hypoxia, give them oxygen. Oxygen is a pulmonary artery vasodilator. If they're fluid overloaded, leg edema, give them diuretics. Sometimes we give anticoagulation, not in all, but in selective cases. Sodium retention is required because you don't want too much sodium, otherwise more pedal edema. We give exercise training, means pulmonary rehab, very similar to interstitial lung disease. Then we give specific therapies for pulmonary arterial hypertension, and there is no way not knowing them. Oxygen, anticoagulation, diuretics is for everyone. Then we give specific pulmonary vasodilators which cause pulmonary artery to vasodilate. These can be calcium channel blockers, endothelin receptor antagonists, phosphodiesterase 5 inhibitors, cyclic guanylate cyclostimulators, prostanoids, and sotatercept. Do I want you to remember these all? No. But I want you to appreciate that pulmonary arterial hypertension is not treated with ACE inhibitors, beta blockers, all that BS. No. It is treated with selective medications. Calcium channel blockers in very rare cases. Otherwise, endothelin receptor blockers, phosphodiesterase 5 inhibitors, cyclic guanylate cyclase stimulators, prostanoids, and sotatercept. Let's review some of these. This is the pulmonary artery. Endothelin pathway is overactive, so it produces a molecule called as endothelin-1, which causes vasoconstriction. Nitric oxide pathway is suppressed, so less nitric oxide. Prostacyclin pathway is suppressed, so less prostacyclin synthase. We need to give a medicine which blocks the endothelin receptor antagonist. It blocks it. To improve nitric oxide level in the pulmonary artery, there are two ways of doing it. For phosphodiesterase time, which is the tadalafil and sildenafil, same thing that we use for erectile dysfunction, can be used for pulmonary artery vasodilatation as well. Similarly, there's another medicine, which is nitric oxide donor, which is a cyclic guanylate cyclase stimulator that can be used. Prostacyclins cause smooth muscle vasodilatation, and there are many ways of giving it. It can be subcu, it can be oral, it can be IV, it can be inhaled. So that can be given to cause vasodilatation. And the next drug, so calcium channel blocker, rarely. Endothelin receptor blockers, yes. Phosphodiesterase inhibitors, yes. Cyclase, guanylate cyclase stimulators, yes. Prostanoids, yes. And the new drug is sotatercept. This is a new concept in medicine. You can appreciate how far, how deep the science has gone. If you take a cell, it has certain molecules on it which are pro-proliferative and anti-proliferative. I will not go into the names of these because I don't want to confuse the students here, not necessary. Appreciate the science. The smooth muscle of the pulmonary artery and endothelin lining of the pulmonary artery have molecules on it, receptors, which produce vasoconstriction or pro-proliferation and anti-proliferative. They are fighting with each other, usually in a balance. So in our patients, the pro-proliferative activity goes down. The pro-proliferative activity is increased, anti-proliferative activity is down. What sotatercept does, it goes into the cell, it decreases the pro-proliferative receptor expression, and it increases the expression of anti-proliferative molecules. When that happens, patients' vasodilatation starts to occur. So, three drugs which are common: diuretics, warfarin, oxygen, everybody gets. Rarely we use calcium channel blockers because its side effects, and it's not very effective once the fibrosis, it becomes irreversible. Lost the diagram. I'll come back to it. The sotatercept decreases the expression of pro-proliferative molecules, increases the expression of anti-proliferative molecules. So suddenly the smooth muscles and the endothelial lining starts to dilate. Patients' pulmonary vascular resistance increases, pulmonary artery pressures go down, pedal edema goes down, patient's shortness of breath improves. He's able to have greater exercise tolerance. So there are three endothelin receptor blockers, they can be combined to nitric oxide pathway, phosphodiesterase inhibitors, or soluble guanylate cyclase stimulators. Riociguat is the name. Prostacyclins are many. There's some receptor antagonists. They basically improve the thing. And lastly, sotatercept, which is activin signaling pathway. This is called as activin signaling pathway molecule. This is a new in class. I want you to know this. 4 different types of medicines for pulmonary hypertension are endothelin receptor blockers, soluble nitric oxide donors, soluble guanylate cyclase stimulators, PDI inhibitors, prostacyclins, and fifth one, activin signaling molecule, sotatercept. So treatment is complicated, and based on patients' severity of the disease, we will look at it and then do that. Everybody needs to get confirmed with a right heart catheterization. We give them a vasoreactivity testing, which is positive, then they will get calcium channel blockers. But I can tell you, most of the patients that come to us, by the time they come to the physicians, they have the advanced irreversible disease. We give them multiple medications, combine phosphodiesterase inhibitors, endothelin receptor blockers. Sometimes we'll combine with prostacyclin and sotatercept. So all our patients are on multiple medications at this point of time. And if they fail, they will get lung transplant. Few words about group 2 pulmonary hypertension. Basically, it's a pulmonary venous hypertension. Pulmonic veins are engorged. That's vasodilators, beta blockers, diuretics, digoxin, etc., etc. I want to stay away from this. What about pulmonary hypertension in group 3 patients? A good example of that is COPD, interstitial lung disease, kyphoscoliosis, etc. In this condition, you treat the underlying condition. You treat the underlying condition. You treat ILD, you treat COPD, etc. Except in ILD, in these cases, you give them, decrease the work of breathing by giving non-invasive ventilation. Remember, CO2 goes up, we give them a non-invasive ventilation, avoid atelectasis, oxygenation, etc., etc. I want you to know, in patients with interstitial lung disease with associated PH, the drug of choice is treprostinil, a type of prostanoid. Treprostinil. It's an inhaled form. This is the only drug approved for interstitial lung disease related pulmonary hypertension, so it has tendency of showing up on the exam. Inhaled treprostinil for interstitial lung disease. What about group 4? Those who have non-resolving clots despite best of the anticoagulation. These patients we study by looking at ventilation perfusion scans, and you see, I'm not going to show you VQ scans, but this patient has multiple perfusion defects. The treatment of group 4 pulmonary hypertension is surgery. It's called as thromboendarterectomy. Thromboendarterectomy. In this is some of my patients. You can see the surgeons go just like bypass surgery, open the chest, open the pulmonary artery, remove the clots. This is one of the rare conditions in medicine. Patients comes to the hospital, he's about to be intubated. After the surgery, he gets so much better, he does not require oxygen, he goes back to playing tennis. Group 4 pulmonary hypertension, in which the chronic thromboembolic disease pulmonary hypertension, CTEPH as it's called, is treated with surgery. If there is residual pulmonary hypertension at the end, the drug of choice is riociguat, which is the cyclic guanylate cyclostimulator, riociguat. So for group 3, ILD is treprostinil. For group 4 is the riociguat if surgery is not possible, or if post-surgery patient still has pulmonary hypertension. We go through a very significant algorithm. Patients is operable or not, and then we can do some other things as well. Just to realize that you follow these patients very closely, and if they are not an operable candidate, or if they've been operated and still not doing good, riociguat will be the drug of choice for chronic thromboembolic disease. Sometimes we do something called as balloon pulmonary angioplasty, in which we pass a catheter through the neck and dilate the pulmonary arteries as well. So here it is, people, the summary slide. For group 1, idiopathic type, you use endothelin receptor blockers, phosphodiesterase inhibitors, cyclic guanylate cyclostimulators, prostanoids, and sotatercept. For group 2 is the cardiology business. I stay away from that. Group 3, treat the underlying condition, specifically in interstitial lung disease, you use treprostinil. Group 4, you do surgery. If not, you can use cyclic guanylate cyclostimulators. Riociguat is the drug of choice. Group 5, treatment is beyond the discussion of this lecture. It's done on a case-by-case basis. In summary, pulmonary hypertension patients die of right heart failure. Pulmonary hypertension Definition is mean peer pressure more than 20 millimeters of mercury. It will be divided into pre-capillary, post-capillary. Post-capillary is left ventricular problem. Pre-capillary types can be idiopathic lung disease, chronic thromboembolic disease. In these cases, you would use specific vasodilator treatments. For group 1, you will use a couple of these. Group 3, treprostinil, and group 4, Yosiguat. That you must know. Echo is a screening tool. Right heart catheterization is the way to diagnose this condition. I'm going to stop here at this point of time because I think we probably are about to be finishing on time. But I've given you a good overview of what right heart failure is and how does it occur in different kinds of dysfunctions in the lung and the heart. How we divided it from starting from the left side, which is congestive heart failure, starting on the right side, which can be idiopathic type, which is PAH, lung type, which is COPD-ILD, or chronic thromboembolic disease. Forget the rare types, which is not important for this discussion. We also reviewed the medicines and the workup of these patients. Keep in mind, all these patients are listed for lung transplant as well if they don't do well. I will stop here. I'll take any question, comments, jokes at this point of time because it's the end of the day. I don't know how much of it is being retained by the students. I'm just impressed that the 31 people are still here and now it's 30 and it's slowly going down very fast. Tomorrow's lecture starts at 4. I like to do it on the Zoom. We just one lecture left and then we'll see if we need to review anything. Okay, any questions at this point? Otherwise, we're good. We'll start at 4 o'clock tomorrow. Thanks very much, people. Appreciate it.